Good morning, everyone. Welcome to our webinar today, Leading with Heart, Boosting Vaccine Confidence. As you all know, ABC has been engaged in the trenches in this COVID-19 syndemic for our diverse populations. Since April of 2020, we began a series of webinars to educate you, our colleagues, as well as the general public and our patients about the latest information related to the COVID-19 syndemic. Today, to get started, I am Dr. Michelle Albert. I'm the ABC president, and I would like to take this moment to offer an in memoriam for General Colin Powell, former Secretary of State and retired general, 1937 to 1984. Dr. Martin Luther King Jr. once said, "Everyone can be great because anyone can serve. You only need a full heart of grace, a soul generated by love." Please, let us take a moment of silence to reflect upon and honor former Secretary of State and retired General Colin Powell. The ABC dedicates this webinar, Leading with Heart, Boosting Vaccine Confidence, to honor former Secretary of State and retired General Colin Powell's contributions and dedication to helping people live their best lives while in service to his country. He will forever remain an inspiration. He passed away on Monday, October 18th, 2021, at the age of 84. In 2010, the ABC honored both retired General Colin Powell and his wife Alma at its Saving for Generations Gala in 2010 for their leadership in, quote, America's Promise, unquote. The Powells were highly respected as advocates for children and as leaders who transcend partisan politics. This wedded nicely with ABC's campaign, Children Should Know Their Grandparents so they can become great grandparents themselves. What a wonderful slogan. The name America's Promise came from Dr. Martin Luther King's I Have a Dream speech, in which Dr. King compared the Constitution and Declaration of Independence to a promissory note. The note, Dr. King said, was a promise that all people, and I've replaced men with people, yes, black people as well as white people, would be guaranteed the inalienable rights of life, liberty, and the pursuit of happiness. Retired General Colin Powell, a son of Jamaican immigrants, embodied the leadership qualities and empathy that all should admire and aspire to in their lives. In his own words,
The longer I have been in public service and the more people have asked me about leadership over the years, leadership ultimately comes down to creating conditions of trust within an organization. Good leaders are people who are trusted by followers. Leaders take organizations past the level that the science of management says is possible. One of my sergeants back in the infantry school at Fort Benning almost 50 years ago, which is where I learned everything I ever got to learn about leadership, was at the infantry school. And he said to me one day, he said, "Lieutenant, you'll know you're a good leader when people follow you, if only out of curiosity." And so they would teach us at the infantry school, no matter how cold it is, Lieutenant, you must never look cold. No matter hungry you all are, Lieutenant, you must never appear hungry. No matter how terrified you are, Lieutenant, you must never look terrified. Because if you are scared, terrified, hungry, and cold, They will be scared, terrified, hungry, and cold. I've gotten away with that many, many times in the course of my career by being scared to death, cold, and wanting to go to sleep. But no, let's go. Let's keep going. Let's go around this corner, if only out of curiosity. And they'll follow you into the darkest night, down the deepest valley, up the highest hill, if they trust you.
Such wisdom. ABC offers our deepest condolences to the family and friends of Colin Powell. We honor his distinguished legacy, and may he rest in peace with God. Next, I have the honor of introducing Dr. Peter Chin Hong. And for those of you who have been following our ABC webinars over the last year, you've all come to know Dr. Chin Hong. Dr. Peter Chin Hong is a dear friend, trusted colleague, first and foremost, dear friend, who is a professor of medicine and associate dean of regional campuses at the University of California in San Francisco. He's a medical educator who specializes in treating infectious diseases. He directs the immunocompromised host infectious disease program at UCSF. His research focuses on donor-derived infections in transplant recipients and molecular diagnostics of infectious diseases in patients with suppressed immune systems. He earned his undergraduate and medical degrees from Brown University before completing an internal medicine residency and infectious disease fellowship at the University of California at San Francisco, UCSF. And he is the director of the year-long inquiry program in the School of Medicine. He is the inaugural holder of the Academy of Medical Educators Endowed Chair for Innovation in Teaching. He's a spectacular teacher, and you'll hear it here today. I will turn this webinar over to Dr. Chin Hong, who will serve as the moderator as well as a speaker, and again, the moderator for the panel at the end of the program. Thank you, Dr. Chin Hong, for your dedication to ABC and dedication to saving the lives of a diverse, not just America, but a diverse international community. Peter.
Thanks so much, Dr. Albert. First of all, I want to formally congratulate Dr. Albert for her election to the National Academy of Medicine. Michelle, you make us all proud. You make us all inspired by you. And I think you're going to inspire many, many generations of not only ABC members, but many other trainees and colleagues, in the US and elsewhere. So thank you. So without further ado, and given our short and packed agenda, I'm going to move on to our first speaker of the day, who's Dr. Makeda Robinson. And Dr. Makeda Robinson is just down the street at Stanford. She is an infectious disease postdoc fellow at Stanford University School of Medicine. She earned an MD and PhD from Stanford University School of Medicine and is currently a postdoc infectious disease specialist at the university. She's a recipient of a Howard Hughes Medical Institute Medical Fellowship and is a Jackie Robinson Foundation Scholar. Her current research, funded by the AP Giannini Foundation Fellowship, focuses on understanding virus-host dynamics in the setting of emerging pathogens like COVID. In response to the ongoing COVID-19 pandemic, Dr. Robinson has also developed a translational research project studying age-dependent differences in the host immune responses to COVID-19 through the Stanford Innovative Medicines Accelerator Program. In parallel, she has been working to spread evidence-based information about COVID-19 through her column, Ask an Expert in Very Well Health, an award-winning online health resource. She's also commented on current issues surrounding the response to COVID-19 in major media outlets, including CNBC, USA Today, The Huffington Post, and Healthline. Dr. Robinson, welcome to our seminar and look forward to hearing your talk.
Thank you so much, Dr. Chin Hong, for that warm introduction. I will start my slides here. Great. So thank you again for that warm introduction, and thank you again, Dr. Albert, for the opportunity to speak to you all today. And I'm going to talk a bit about vaccine biology in the time of COVID-19. So first, I did want to talk a little bit more broadly about the development of these vaccines. So many of you may have had patients come and ask you, how can we trust a vaccine that was developed so quickly? And I think there are several underlying reasons why we were able to develop safe and effective vaccines so rapidly. First of all, we had already identified an important immunogenic antigen, the spike protein, prior to the COVID-19 outbreak through research on the original SARS virus and related coronaviruses. In addition, the vaccine platforms that we used only required the viral sequence to begin developing the vaccines. And once the first in-human trials were started, because of the large influx of financial support that was given to this effort, our industry partners began the large-scale manufacturing of these vaccines earlier on in the timeline. So when we traditionally think about vaccine approaches, we traditionally think of conventional vaccines, including live attenuated and inactivated viral vaccine approaches. And these are composed of weakened or killed virus and have several pros and cons. So it does require us to grow a large amount of these viruses as the starting material for these vaccines. However, they can often generate lifelong immunity. However, during the COVID-19 outbreak, genetic vaccine strategies such as mRNA and adenoviral vector approaches had several advantages. So as I mentioned, they only require the viral sequence. They do not require us to handle any live virus. So it's not possible to transmit SARS-CoV-2 throughout any of the process of creating these vaccines. And the scalability of these vaccines is higher. So for the rest of my talk, I'm going to focus specifically on these next generation vaccine strategies. However, there are other types of vaccines that I haven't mentioned here, such as protein subunit vaccines and viral-like particles. Starting with the mRNA vaccine approach, as you all know, we currently have two vaccines that are being utilized in the US, the Moderna vaccine or Spikevax, and the Pfizer BioNTech vaccine or Comirnaty. And through some of the early clinical trials and more broad usage of these vaccines, we have identified some rare side effects. So for those who have an allergy to any of the components of the Moderna or Pfizer vaccines, there have been some cases of anaphylaxis. So this has occurred in about 11.1 cases per million doses given. And another rare side effect that I'm sure many of you have heard about, which is the advent of myocarditis and pericarditis, which has occurred in about 12.6 cases per million second doses given. And this side effect has a specific demographic target, so it's more common in adolescent males, occurring several days after the second dose, and usually resolves quickly on its own. However, we're still unclear about what the mechanism is for the development of this inflammation, and the FDA has been sort of watching this to evaluate how broadly we should continue to approve this specific vaccine. The next approach is the adenoviral vector vaccine. So there's only one of those vaccines in circulation in the US, the Johnson & Johnson vaccine, but there are several others that are circulating throughout the globe. So the AstraZeneca vaccine or Covishield, which was developed in the UK, Sputnik 5, which was developed in Russia, and Covidicea, which was developed in China. And there are some specific rare side effects that are associated with the Johnson & Johnson vaccine. So that was the thrombosis and thrombocytopenia syndrome, or TTS, which occurs, again, rarely in about 7 cases per million doses given. And this side effect also has a specific demographic target. So usually women of childbearing age, at least 2 weeks after the initial dose. Now that we know some of the risk factors of sort of the risk profiles of these vaccines, I wanted to talk a bit about how these vaccines create lasting immunity. So the spike sequence, the mRNA spike sequence is encased in a lipid nanoparticle for the mRNA vaccines or inserted into an adenoviral vector. And once you get your initial shot or injection into your muscle, these vaccines are taken up specifically by dendritic cells, which are a professional antigen-presenting cell type. Once they've entered into these cells, they do begin to generate more spike protein, which they produce here and present on their cell surface. Once they've entered into the cell, intracellular DNA and RNA sensors do identify this new mRNA or DNA, and this triggers activation of these cells to produce type 1 interferons, which boosts the immune response to these vaccines. These activated dendritic cells can then traffic into the lymph nodes that drain the injection site, and they transmit their antigenic and inflammatory signals to T cells in these lymph nodes. So here you can see the MHC class 2 molecule binding to the T cell receptor, activating this cell to proliferate and differentiate into effector T cells and memory T cells. These T cells can also differentiate into helper T cells that can promote B cells that are S protein specific to differentiate into plasma cells, which are the antibody producing cell type, and memory B cells. And so here you can see the development of both cellular and humoral immune responses to vaccination. So how well do these vaccines really work? So as you all know, the Pfizer vaccine is a 2-dose vaccine, 21 days apart. The Pfizer vaccine has really been leading the way in FDA approval. So it has emergency use authorization for ages 12 to 15 and has full FDA approval for 16 and up. They've also submitted a request for ages 5 to 11. So we may have a vaccine for elementary age children coming up soon. Their vaccine efficacy has been high, so 91% for symptomatic disease and 95% against severe disease. And they have had a reduction in vaccine efficacy associated with the Delta variant. Some studies have showed just a modest drop to around 88%, but other studies have shown that it may drop to below 50%, which was part of the emphasis for the beginning of the booster shot campaigns. The Moderna shot is fairly similar, so it's 2 doses, 28 days apart, but this vaccine has still stayed as a vaccine only for adult populations, so it's given to those who are 18 years and older. They have submitted to the FDA for approval for ages 12 to 17, so the adolescent sort of population. However, the FDA has decided to delay some of that decision-making, looking into some of the issues around heart inflammation. So we'll get some more information about that relatively soon. The vaccine efficacy, again, is incredibly high and very similar to the Pfizer vaccine. And there has been some recent data showing that the Moderna vaccine may be actually more efficacious than the Pfizer vaccine. So in this New England Journal of Medicine article, they found that healthcare workers that received the Moderna vaccine had a reduced percentage of infections, and that those who received the Moderna vaccine maintained their prevention of hospitalization over a longer period of time than Pfizer. The Moderna vaccine has also showed reduced efficacy to the Delta variant as well, which is why there's been discussion about booster shots for the Moderna vaccine as well. And then lastly, the Johnson & Johnson vaccine has gotten a lot of additional focus recently. This was originally a single dose vaccine, again, for adults over the age of 18. But it does appear that this vaccine may work better as a 2-shot regimen. And Johnson & Johnson has recently submitted some evidence showing that a 2-dose regimen will boost the vaccine efficacy up to 94%, so closer to what we were seeing with the mRNA vaccines. The vaccine efficacy of the J&J vaccine has always been a bit lower than the mRNA vaccine. So 79% overall efficacy, about 86% against moderate and severe disease, and they have shown a reduction in efficacy against the Delta variant. And I think also an important and sort of interesting thing to look more into is that it appears that it may not work as well in immunocompromised host populations. So a recent study showed that dialysis patients who were given the Johnson & Johnson vaccine, around 33% of them did not develop an antibody response, and that was compared to 4% with the Pfizer vaccine and 2% with the Moderna vaccine. So where are we now as a country as far as vaccine doses? 66% of the US population has received at least one vaccine, and 57% of the population is fully vaccinated. We've given over 100 million second doses of the Pfizer vaccine, 70 million Moderna vaccines, and 15 million of the Johnson & Johnson vaccine. So while this is a good start, I think as many of you know, when we initially started the vaccine rollout, the thought was that we may need closer to 70% of our population to be vaccinated to reach herd immunity. However, now with the advent of the Delta variant, which is thought to be almost 40% more transmissible than the Alpha variant, and an R0, according to the CDC, of closer to around 8.5, that percentage may need to be even higher. So we still have a lot of work to do. In addition, the worldwide vaccine rollout has lagged the rollout here in the US and Canada. And given sort of like the cases of the Alpha variant and the Delta variant, we've seen that some of these more transmissional variants really can be, wherever they are in the world, will end up in the US. So it's also really important to start thinking about how to disseminate these vaccines more equitably throughout the world in order to protect our neighbors as well as ourselves. So while these vaccines are incredibly efficacious, we have begun to see some breakthrough infections in fully vaccinated people. And so I put this picture of General Colin Powell here to remind us, one, of the risk factors of breakthrough infections, but also to remind us of how important it is to vaccinate ourselves, yes, for ourselves, but also for our communities, and that really these are the people that we want to use the herd immunity for. Breakthrough infections thus far, it's been shown that adults over the age of 65 constitute 74% of the breakthrough infections, and that nearly half of the severe breakthrough infections occur in immunocompromised patients. So these are two patient populations that are at risk for infection, even if they've been fully vaccinated, and are a key component of sort of the initial booster rollout. In addition, the rate of breakthrough infections in non-immunocompromised patients is closer to 1%. So for those who have seen some of the reporting on breakthrough infections and may think that these vaccines are not efficacious, it's important to remember that if you have a good and robust immune response to vaccination, that the risk of breakthrough is incredibly small. And next, I did just want to touch briefly on sort of booster shots. I'm sure that Dr. Chin-Hong will talk more about this, but we have started this rollout, and there have been some recent articles showing that booster vaccinations will improve binding antibody titers, regardless of which booster you get, and that mixing and matching of the boosters leads to a similar increase in antibody titers. But I think interestingly, for those who received an adenoviral vector vaccine initially and then received an mRNA vaccine as their booster, you can see that there was an increase in the immunogenicity. So here you can see this increase after the adenoviral vector booster for those who received it initially. And here, when they got an mRNA vaccine, they reached similar antibody titers to those who initially received the mRNA vaccine. And then lastly, I did just want to touch on some of the new iterations of vaccination that have been brewing. So one, there's been discussions about site-specific vaccinations and increasing tissue-specific immune responses in the lung through intranasal formulations of vaccines. And there has been additional research and development in formulating new targeted vaccines to these variants that have been shown to be more transmissible. And I believe mRNA vaccine approaches may be a more tractable approach when thinking about this, as there has been some concern that we may begin to generate some immunity to the adenoviral vector itself, leading to clearance of that vector. And that may be why the boosters using those adenoviral vectors have lower immunogenicity than the mRNA vaccines. And so with that, I want to thank you for your time and attention and pass things along to Dr. Chin-Hong.
Thanks a lot, Dr. Robinson, for such a great and clear, succinct presentation and a tour de force. What I'm going to do is share my screen now to take you on to the next talk. So what I'm going to do in the next 15 minutes or so is just take you through two specific topics, some of which was covered so well by Dr. Robinson, but I'll just bring in some other perspectives as well. So I'm going to speak about variants as well as boosters. So first, let's talk about variants. We've all been hearing a bit about variants for many months now. I think that people are afraid not of the variants only that we have around, but of the variants that come, and I'll touch a bit about that. So let's just bring it up back to the 30,000 foot level and think about how I think about variants. I just divided into three boxes: the good, the bad, and the ugly. If you think the good, no SARS-CoV-2 infection, of course, is good. But if you think about the best one, it's the baseline, it's the original Wuhan variant. When I think about bad variants, they have increased transmissibility. Delta, of course, everyone knows about, is the poster child of that bad category. Alpha from the UK, originally taken off over the winter in the UK and then the US and around the world, is another example of increased transmissibility, as well as Epsilon, which has kind of gone into the woodworks now in the Californian variant. Now, when I think about the third category of ugly, it's not only increased transmissibility, but potentially increased vaccine evasion. There's a little bit in Delta, but mainly when we think about increased vaccine evasion, I'm thinking about the Brazilian variant or Gamma or P1, the Beta variant first described in South Africa, and some mutations in Mu and Lambda, C1, other variants and sublineages that you might have heard of because they have that specific mutation that may confer some vaccine evasion. But at the end of the day, if you had it to be a variant and you wanted to have one superpower, it'd probably be increased transmissibility. Because as you can see from the graph on the right, Delta has really taken off more than 99% of cases in the United States and more than 90% in many countries around the world. Not because it has as much vaccine evasion as much as increased transmissibility. So when I started looking at slides for variants, I went back to one of my old slides in April of this year, and you can see that we were tracking variants, and you can see that California, Florida, some of the Michigan had some of these variants that we were concerned about. And after a while, we stopped really tracking it because everything was Delta. And you can see that in the most recent CDC slide, it's not very informative because everything is orange. So let's focus in on Delta. Not going to spend too much time on vaccine biology because Dr. Robinson did such a great job. But mainly the reason why Delta is different is because of the place where it sticks onto the receptor in the cells where the virus is trying to enter the body. That part of the virus is called the receptor binding domain, tends to be stickier. And because it's stickier and it's changed by mutations, some of our immune cells can't see it. The antibodies can't recognize that as easily. It still does a decent job. That's why vaccines still work, but it's not quite as easy as Alpha or the original variant. There are a few other mutations that I won't get into that make it not just stickier and easy to get in, but also more transmissible. So a few questions. Is Delta more contagious? A qualified yes. When you compare the various variants, Delta comes way on top, 2.5 times more than the original SARS-CoV-2. And then you can see in ranking, then there's the Brazilian variant or Gamma, then Alpha, then Beta, and then the California or Epsilon variant. Not only that, the viral loads are higher. So it's not only stickier like Velcro because of those mutations in the receptor binding domain, but there's a lot more of it. So it becomes very, very easy to transmit. In fact, people compare it to chickenpox in terms of its transmissibility. And if you look at the x-axis, you can see that it's much more transmissible than the common cold, polio, seasonal flu, MERS, and SARS, and almost as transmissible as chickenpox, meaning that one person on average can infect almost 10 people around them. So let's dive in more deeply into some of the questions and some of the data and try to organize it in our heads. So first of all, do vaccines work against Delta? It seems scary when you look at measures like neutralizing antibodies, because when you look at the various vaccines, Moderna, Pfizer, and you compare the original variant in terms of neutralizing antibodies generated, you can see that there's always seems to be a decrement. So when we first started to see this data, everyone was kind of scared about it. Then you look at prevention of symptomatic infection, and it seems that, if you compare the Delta to Alpha, it looks much worse, particularly in Israel, some of the emerging data in the US, as Dr. Robinson talked about. And the other information we got is that you can't just get away with one dose like in the original variant or with Alpha. You need both doses, probably above 90% in good times with two doses, about 70% in one dose. Of course, that's changing now as people are waning immunity for infection. Now, when we think about the outcomes we care most about, which is hospital admission, you can see that Delta is still in the general population, tending to be pretty good, above 90% vaccine efficacy in terms of preventing hospitalizations. So when you think about whether or not a vaccine works against Delta, it depends on how you define your outcome and what your golden apple is and what your prize is. And as an infectious disease doctor, I think hospital admission, severe disease, and death is really the golden apple for me. And it's nice to prevent infection, and we'll get to that in a little bit. So do you get sicker with Delta? I think people know this by now, but it could feel like allergies or bad cold if you get breakthrough infections with Delta. Top 5 symptoms in vaccinated are headache, runny nose, sore throat, loss of smell, and sneezing. Sneezing hadn't been seen before Delta as a symptom. And now everybody knows that with any symptom you have, you should get tested. There's some data around the world showing that you not only have different symptoms as breakthrough, if you're unvaccinated, you can have more serious disease. And that probably is more of a function of the amount of virus that's produced by Delta. Again, 1,000 times more than the regular Wuhan variant. And you can see that in various countries, more hospitalizations, more ICU admissions, more increased death and mortality. Do our current treatments work against Delta? Generally, yes. There are some antibody treatments that have been discontinued, like Lilly, where there's a decrement in the activity of the monoclonal antibodies to Delta, but all the current ones, including Regeneron and others, work quite well. So let's talk about what's coming. I think people have heard about Lambda. They got nervous about Lambda. First seen in Peru, kind of took off to more than 90% of cases. Delta's kind of keeping it under wraps. Hasn't really penetrated other countries, including the US. Then people started to get worried about Mu. First seen in Colombia, more than 90% at some point, never really penetrated the dominance of Delta in the United States and around countries around the world. The reason why people were worried about these variants was because they had some more potential vaccine evasion, but it never really turned out to be much. And the latest kid on the block, of course, is what we call a sublineage of Delta or a child of Delta, because every 2 weeks, the virus is mutating. And this AY42 is just one of the progeny of Delta, where there's some mutations. Personally, I don't think it's much of a big deal because the mutations are not in that receptor binding domain, but it's taking off in the UK right now from 0 to about 7 to 10% in a few weeks. People are worried that with increased travel, we will see more AY42 in the US. So it's definitely something to look out for. So let's turn our attention now to boosters. Why are we thinking about boosters? Dr. Robinson gave some great framework for thinking about this, and I'll just give you some more evidence around it. So Israel started doing this on July 30th. They started with over 60-year-olds, and the reason why they did it was that their data showed that they're predominantly a Pfizer country, and the ability of Pfizer to prevent severe illness in over 60-year-olds dropped from 81% in July from 97% in April. Now, Israel defines severe illness differently from the US, which is just really oxygen saturation less than 94%, whereas the US criterion is more stringent. Hence, sometimes you may see differences in performance of vaccine from one country's study to another. So they began giving third vaccine booster shot on July 30th. And if you see on the graph on the right, in the red line, that's the older than 60-year-olds who've gotten a booster. You can see that that line has really gone down, disproportionate to the other age groups. So they looked at more than 1 million people who've gotten boosters and non-boosters and compared them between July 30th and August 31st, so not a long time of follow-up. More than 60-year-olds, if they got a booster, the second dose is more than 5 months earlier. And in the booster group, in general, there were 11 times lower odds of infection and 19 times lower odds of severe illness. Although it was a short follow-up period, but the data was compelling, at least for this older population. In the United States, we began seeing some data first from the CDC in early September, showing that in 9 states between June and August of 2021, when Delta was circulating, the vaccine efficacy against COVID-19 hospitalizations diminished for the over 75-year-olds from, compared to the younger than 75, 76% versus 89%. And the decline in efficacy was most pronounced if you got a Pfizer and J&J. So if you look on the right side, compared to unvaccinated folks, if you got a Pfizer, the vaccine efficacy in the Delta era was 80%. If you got a Moderna, it was 95%. And if you got a J&J, it was 60%. The CDC then followed up with a longer duration of follow-up period and more robust database, looked at 3,700 people. Again, Delta was mainly circulating. And what they did in this particular analysis was look at the vaccine efficacy against COVID-19 hospitalization 2 weeks versus 4 months after the vaccine booster. So if you got Pfizer, and this is pre-booster data. If you got Pfizer 2 weeks after you got a vaccine, the vaccine efficacy was 91%. 4 months after the vaccine, it dropped down to 77%. And there was not much of a decline in Moderna, 92% to 93%. And J&J couldn't really compare the 2 time periods because there weren't as many people who got J&J in the database, which has kind of been the tale of J&J or Team J&J. There hasn't been a lot of data just because the number is so small when they look at these subgroup analyses. So let's go into the data very briefly with each of the different 3 vaccines for boosting. And Pfizer submitted data showing in a small study of 300 people, if you got boosted 6 months after your second dose, first of all, there are no safety concerns. Neutralizing antibodies increased by 5 to 7 times compared to 1 month after the second dose. But the original 2-dose regimen was still protective against severe disease, which is kind of the theme for this whole talk. In Moderna, there was even more poultry data. There are no safety concerns at all. They use a half dose for their boosting study as opposed to the regular Moderna dose, neutralizing antibodies 2 times more compared with 1 month after the second dose after a booster, and neutralizing antibodies 4 times more in 88% of the population compared with 1 month following the second dose. So 88% of people had a tremendous increase in neutralizing antibodies. Some people didn't. On average, it was 1.8% if you got a booster. People said that the reason why you didn't see such a robust increased odds was because Moderna was already doing pretty well. What about J&J? Again, not very good data, and there are 50 million people who are eligible for boosters in the US. So they looked at what we do know is antibody levels remain kind of stable over time. The hospitalizations remain steady over 6 months after just 1 shot, but not as good as Pfizer or Moderna. So J&J presented 2 sets of studies. One was, what if you got a second shot after 2 months? And you looked at vaccine efficacy with the outcome of mild to severe disease. If you got 1 shot, it was 74% effective. If you got 2 shots within 2 months, it shot up to 94% and 100% protective against severe disease. And again, 3 to 4 times increase in neutralizing antibodies. J&J also presented an intriguing study looking at 2 shots over 6 months. What if you got your second shot 6 months later? They only had antibodies as an outcome, but 1 week after getting the booster shot at month 6 or later, 9 times increased neutralizing antibodies. 4 weeks after following up these people, 12 times increased neutralizing antibodies. So J&J, to summarize, it seems it's like wine. The longer you age it, the better your antibody response is. It's been pretty stable, but at baseline, not as good as Pfizer Moderna. But if you get it, it kind of stays this stable over time. If you get a booster, the more you wait after that booster shot, particularly if you get it after 6 months, the more your antibody levels shoots up. So, Dr. Robinson mentioned a little bit about the mixing and matching. I'll just present just one slide on this, which is the NIH mix and match study that she showed the data on, which they looked at 9 groups of 50 each. They just basically compared different combinations of J&J, Pfizer, and Moderna, phase 1 to 2 open label trial. People got boosted if they were at least 12 weeks after the full vaccination, which is 1 shot for J&J or 2 shots for Pfizer, Moderna. There were no safety concerns. And then the striking, surprising news, although a small study for everyone, was if you receive J&J as the first vaccine, your antibodies shot up 4 times with a J&J booster, 35 times with a Pfizer booster, and 76 times with a Moderna booster. Note that this Moderna booster was a full dose booster as opposed to the Moderna studies, which for boosting, which was a half dose, and the FDA and likely the CDC will probably recommend that half dose as a booster shot for Moderna. Finally, I'll end on who is eligible for boosters. Well, I presented data, and the data is very clear. We are not being flooded in hospitals, except in 2 groups that Dr. Robinson mentioned: older individuals and those who are immunocompromised. For everybody else, it's really unvaccinated people, more than 90% of hospitalizations. So it's not just the science we're reacting to as a society, we're reacting to values. So everyone agrees that over 65 should get boosters. Everyone agrees that immunocompromised should not only get boosters, they should get like a bunch of extra doses because not everybody will respond even after a 3rd dose. I think medical comorbidities, ongoing exposure, and older than 40, as a society, we want to probably focus on infection, not just serious disease, hospitalizations, and death. And I think that's where the country is moving to based on President Biden's original comments. And that's the reason why you're going to see boosters opening up probably to a wider range of people over time. After all, we do have boosters that typically are used in many other vaccines: measles, mumps, and rubella, hepatitis B, human papillomavirus. They all come in 3s, 2 in the beginning within a month, and then 1 several months later as a booster, so prime and boost. So what if you got a Pfizer? Sure, you can get a booster. You can stick with Pfizer. You can get a Moderna. You could even get a J&J if you had a bad reaction to an mRNA vaccine. But I think most people are probably going back for an mRNA. What if you got Moderna? Probably not an urgency to rush out and get a booster. But certainly if you're older than 65 or immunocompromised, I would definitely get one. If you get J&J after 2 months, I think you should definitely get another shot. J&J has not performed as well as the other vaccines, but they are very stable over time. And I think you will definitely be able to boost it. Whether or not you should get an mRNA or J&J, the feds are probably not going to come down on a recommendation for that. Personally, a lot of people are probably going to get an mRNA after their J&J shot. And Dr. Robinson already talked a lot about Colin Powell, but again, he really was the perfect storm of older. He was age 84. He was immune compromised. He had multiple myeloma, which attacks plasma cells, which are the factories that produce antibodies. So if you take down those factories, you can't even make antibodies, even if you get 1 million vaccines. And he also had Parkinson's, which was just a minor contributor, but certainly didn't help. Probably had a lot of people coming in and out of his life to help take care of him. So thanks very much for your attention. Now turn to our next speaker, who's Dr. Tayson Bell. And Dr. Bell is an assistant professor of medicine in the Division of Infectious Diseases. and pulmonary critical care medicine at the University of Virginia. He's also director of the Medical Intensive Care Unit and director of the University of Virginia, UVA Summer Medical Leadership Program, which is a medical school preparatory program for underrepresented and disadvantaged students. Dr. Bell has been a key leader in UVA's response to the COVID-19 pandemic. He was instrumental in leading a team of engineers, architects, seamstresses, and nurses to design, produce, and distribute personal protective equipment for the Charlottesville area and Commonwealth of Virginia. He's part of an innovative rapid deployment team that provides in-person and telehealth care support for long-term care facilities overwhelmed with COVID-19 outbreaks. Dr. Bell was also a co-principal investigator for the NIH-sponsored remdesivir trial, the first drug proven in a randomized study to be effective for the treatment of COVID-19. Dr. Bell, take it away and look forward to hearing your talk.
Thank you, and it's a pleasure to be here to speak with you all. So my primary role is as an intensive care physician. I practice at the University of Virginia, as mentioned, and what I wanted to do is just, so many times my staff and I talk about, what it's like to take care of patients in the ICU, and we say that if people actually knew what it was like here, people would run to the vaccine if they were unvaccinated. So I wanted to give a little bit of a window into the world of the ICU for critically ill patients. So I like to start with my opening message. A lot of times we say, what's our closing message? But I want to start with the opening message that really taking care of COVID-19 patients has been one of the most difficult things that I've ever done. Now, these patients are incredibly sick, are incredibly complex. They remain sick for a very long time. And so the intensity of the care, where we're used to doing it for maybe a week or maybe even two, it can sometimes go on even longer than that. And that's even more of a strain on the patients, the families, and ourselves, to be honest. And then what's also been heartbreaking is that, of course, the Black and Brown communities have been more affected by severe COVID-19. So, for example, Black and Hispanic Americans have lost 3 years of life expectancy compared to 1.2 years for white Americans. And we've seen that in the ICU, especially last year in the midst of a wave before we had vaccines available. So these are all kind of, overlying everything that I'll speak with you about. I wanted to start with an overview. So I've done too many specialty training pathways, but mostly I'm a generalist. My two specialties do not own an organ system, and if someone's critically ill, we take care of everything that's going on. So I'll just start from head to toe, because that's actually what I do for my most complex patients. What are the issues from head to toe? So starting at the head, one of the things that we see very commonly in the ICU are that there's brain dysfunction, and that can manifest either with confusion or what we call delirium. And part of it could be from the disease itself, from COVID. The virus actually does attack part of your brain cells, and science has shown that. But we also have to use medicines frequently that cause really deep sedation, almost similar to anesthesia if you're going for a surgery, except it might last for days or weeks on end, and that can cause a decline in brain function as well. And then we've seen a higher incidence of strokes in people who have had COVID-19. It does cause your blood to be more sticky and cause more blood clots. So we've seen a lot of issues with brain dysfunction with COVID-19. When we talk about heart function, that's also something that we struggle with in the ICU. So there has been a lot of discussion about myocarditis or heart inflammation in relation to the vaccines. But the thing that we need to keep in mind is that COVID-19 actually causes that a much higher proportion. So you're much more likely to get that from COVID-19 itself than from the vaccine. And so we've seen heart inflammation lead to heart failure or shock, which is when you're not able to get blood and oxygen to your vital organs the way that you need to. We've also seen a higher incidence of heart attacks for people with COVID-19. That can either be related to direct inflammation or just the stress of being in the ICU and having your lungs under attack by the virus. It puts a strain on the heart makes it have to produce and work even harder. And then when it comes to the lungs themselves, of course, this is a disease that primarily attacks the lungs. And so we see a lot of different diseases and after effects from that. So first, being on the mechanical ventilator, which I'll get to later, is associated with a lot of different complications just because of how invasive it is. And it can cause a stress to the lungs, even though it's something that we do sometimes when we have to. Pneumonia is what COVID-19 causes when it gets deep down, but it also makes you more at risk of having traditional pneumonias like strep pneumonia and some of the bacterial pneumonias. And we see a lot of those. Actually, I'm on service now, and probably 80% of my patients on the ventilator have an additional pneumonia on top of COVID-19. Fluid accumulation can happen in the lungs, and that does not help with the lungs' job of getting oxygen into the blood and carbon dioxide out of the blood. Because of the lungs being so stiff, sometimes they can cause collapse off the lung, and we have to actually put chest tubes in to try to re-expand it. And then blood clots in the lungs that are called pulmonary embolus. They interfere with gas exchange and can put strain on the heart as well. So these are all complications that all of my patients are at risk for, and many of my patients already have, that are just isolated to the lung. And then if we move down further, gut dysfunction is something that we see very commonly. So patients who have impaired ability to move their gut and have bowel movements, infections can come as a result of that. And then related to that, nutrition status, because if you have a breathing tube in, you obviously are not able to eat food through the mouth. You're often getting food through a tube that goes in through the nose or the mouth into the stomach. That's not a replacement for your normal sort of nutrition. And so it's very common for these patients to have nutritional deficiencies, and nutrition is so important to fighting infection and getting better in general. There was actually a patient who the longest break I've had from the ICU has been a 3-week break. And I had a patient who was there at the beginning and then there when I came back. And in between those 3 weeks, he had lost about 20 or 30 pounds and just looked a shadow of himself. And I actually thought it was a different patient. I recognized the name, but I thought this must be somebody different. It was the same patient, but their cheeks were sunken in. They lost so much weight. They were really a shadow of themselves. Being stressed in the ICU can put you at risk for having stomach ulcers. And so I have a patient actually now who has a gastrointestinal bleed from the stress of being in the ICU, caused a stomach ulcer, and that led to a bleed. And so we're struggling with that as well. And then many of our patients develop kidney failure. Even those who come in with normal kidneys, many of them go on to develop kidney failure and have to go on dialysis machines. And so that's something very common that we see. We have to put catheters in people very frequently, and anything that is in your body that you weren't born with is a risk of infection. And so a tube that goes into your bladder so that we can carefully track your urine output or how much pee you're making, that can make you at risk of having infections, and having urinary tract infections or UTIs are something that we very commonly see. And then because patients aren't moving that frequently or sometimes even paralyzed, the severe muscle weakness can result. So patients who even make it out of the ICU, they often have to relearn how to walk again. They don't have the muscle strength to get themselves out of bed, take care of themselves, get around. It takes a long time to build that back. And even if you can, a lot of times patients don't get back to their prior functional status because of that. And then the last thing I'll say is that blood clots have been very commonly seen in COVID-19. It does cause a lot of inflammation that makes you more prone to have blood clots and all the problems that come along with that. So it's a complex disease. We tend to focus on the lungs, but it causes issues really from head to toe in the body. This is a mechanical ventilator, and we've talked about mechanical ventilators a lot in the midst of the pandemic. Early on, pandemic shortages, and are we going to have enough ventilators? And luckily, we do have a good supply, although there are some areas in hospitals that are running out or very thin on ventilators even at this point. This is a machine that basically works to replace the job of the lungs. It puts in a high concentration of oxygen, even up to sometimes 100%. into the lungs, and it also helps to remove carbon dioxide, which is kind of the byproduct of when our body processes oxygen and uses it, we have to get rid of carbon dioxide. So the ventilator helps with both of that. Now, because as you can see here, this is a tube that goes down your mouth and into your throat, is very uncomfortable. So you can imagine if you put a finger down your throat, you gag. The same sort of thing happens. So you have to actually give patients often a lot of medicine that goes to an IV to make them sedate enough that they can actually tolerate this. And that can lead to complications that I mentioned before. It's not actually a therapy, so I wouldn't consider it something that makes a patient better. What it does do is allow us to have time to treat the underlying cause, and hopefully when the lungs get better, we can then remove the ventilator. But the problem is COVID-19 causes so much destruction to the lung tissue. So on the left over here is a normal lung. The little boot-shaped thing in the middle is the heart. The tall thing in the middle is the spine. And then on the both sides of that, you see normal, healthy lungs. And when you're looking at lungs, they should be filled with air. And so you should see a lot of black there because air doesn't reflect back the x-rays. So that's a nice normal lung on the left. And if you contrast that with on the right here, COVID with a patient with COVID-19, it almost looks like I took a cotton ball, dipped it in white paint, and just blotted it all over the chest x-ray. And that's basically what it looks like. So all that white that you see are the lungs that are now filled with fluid. And that could either be water, blood, inflammatory cells, many different things. But anything that's inside those spaces that are supposed to have air is no longer able to really exchange air and oxygen and carbon dioxide. And it takes a long time for lungs in this condition to really get better. And so patients are on the breathing machine for a really long time. As you can also see, there are some lines and tubes. Some of these are heart monitor clips that go over the chest so we can keep a close eye on the heart. This garden hose size thing here is actually another machine that's called ECMO that I'll get to. It stands for extracorporeal membrane oxygen. Then this is essentially a lung bypass machine. I put a picture here just to show how busy this setup is. This is a patient who has very severe lung disease. And this machine basically removes blood from your body that has poor oxygen levels and high carbon dioxide, and it replaces it with high oxygen and removes the carbon dioxide and puts it back into your body. It's one of the most invasive things and aggressive things that we do for patients. And it takes a lot of resources. There's 2 people who sit by and watch the machine the whole time that it's running. And lots of different things can happen. There are lots of other drips and pumps that go along with it. And all these patients, for the most part, are also on a ventilator as well. And so it's very intense. It's associated with a host of complications, but this is really the most advanced therapy that we offer. And because of that, we only have a few of them. And my hospital actually does have a crunch on our availability to have these machines functional and operational right now. I want to also just mention pregnancy and severe COVID-19. And, this picture here on the right is a picture of a baby crash cart. And this was a day I was walking in the ICU. We had 2 patients who were pregnant. They were both obviously young women, pregnant in their 3rd trimester. And we have an issue here in our country with pregnancy and vaccination. They are one of the least vaccinated adult groups in the country. Only about 1/3 of pregnant women are actually vaccinated for COVID-19. And, lots of reasons why, but there's a lot of concern around safety and efficacy or safety primarily of the vaccines for those who are pregnant, although we haven't had any evidence that shows that there are any detrimental effects for the vaccine. It's very safe for both mom and baby. But because it's a low vaccinated group, we are seeing women with complications. And just to be very frank, having COVID-19 is a risk factor for severe disease if you are pregnant. Pregnant women are more likely to have severe disease. And even before that, they're more likely to have preterm labor or early pregnancy loss. Now, this patient was on the breathing machine and oxygen levels are dipping down low. And when that happens, sometimes you have to deliver the baby emergently. And so we actually have to keep this cart outside the patient's room in case we have to emergently deliver the baby, so that we can have a team to work on the baby and we have that cart there to assist with that. But it's one of those reminders, these are not the things that you're supposed to see in the ICU. You're not supposed to see pregnant women in the ICU. You are not supposed to see crash carts in the ICU. And COVID has made that more or less something normal that we see. And I don't want to normalize that. We have to make sure that we get pregnant women vaccinated. These stories are only getting sadder. And I think because we're in an era now where vaccines are widely available and they can prevent severe disease. Each case that comes in is even that much more sad. We're now in the midst of vaccine requirement debates in the public sector. So Chicago famously is going against Mayor Lightfoot's requirement. Mayor de Blasio in New York, the police union is resistant to that. Their fighter airline pilots, et cetera. These are all being reported now, but these conversations make me think about a patient who died recently. This was a picture of the American flag that we had to find from somewhere in the hospital because he was an active service member who died of COVID-19. He had recently returned to the United States. He had been stationed overseas and wanted to get vaccinated when he got back to the United States. Though his family didn't classify him as an anti-vax person, but just said he hadn't gotten around to it yet and he was planning on it. But they were a lot busy. He had just moved back to the United States. There were lots of things going on, just hadn't gotten around to it. The Pentagon actually issued a mandate that required vaccination, but it hadn't taken effect yet. So he wasn't required to get vaccinated. Which was very sad because if the vaccine requirement had been in place, he likely would have been vaccinated. And I don't think he would have ended up in the ICU. He was my age. He was completely healthy, had no risk factors at all. He was active military. He was very fit. He was very in shape. He was not the kind of person who was supposed to have a severe illness from COVID-19. But here we are, and I'm taking this picture as he rolls down the hallway and he leaves behind 2 young children. And so when we think about these vaccine mandates, what we're really talking about is life and death. And I had the choice between someone who's angry because they had to get vaccinated, but they're alive to be angry. I'd rather have that. So this picture always reminds me of what's really at stake here. The stakes are also very high. Our ICU is in a new building that has this wonderful view that overlooks Charlottesville. This is facing north. And whenever we have a storm come in, it's always kind of cool to see. You can watch the clouds kind of roll by. But even though this is a beautiful picture of a storm coming in, what this means is that helicopters can't transport patients to our hospital. And this storm rolled in while we had a patient who was at an outside hospital that the patient was on a mechanical ventilator. They needed to be put on that specialized ECMO machine. And this storm got in the way of transport. And so that patient who was too far away to drive safely to our hospital ended up passing away without a chance to be put on that therapy because we couldn't get him to that hospital. So, every sort of thing that you would think of as, it's benign or part of normal life becomes so much high stakes in the midst of this pandemic because, something like this could be the difference between life and death, even though it's, we just look up in the sky and see a storm's coming in, that might mean someone may not be able to live the next day. And last, I should say that the strain on healthcare workers and families has been just absolutely tremendous. Because of COVID-19 restrictions, families are not allowed to visit as freely as we would like for them to. And that puts the strain both on family members and on the staff themselves because we serve as a bridge between family members being at the bedside. I mean, the other thing that's really heartbreaking about this is that because we've seen so much death and destruction from COVID-19, patients and families often know what's to come. My patient who died a couple of days ago had before we put a breathing tube down, she looked at me dead in the eyes and said, "I'm going to die, aren't I?" And said it in a way that she just understood what this meant. And she asked me, and am I going to pull through this? And, she had high risk factors. We had to be honest with her and say, we don't know, but she knew what was about to happen. And sure enough, she did pass away. And so that knowledge of, this is not our first time around with this. And many people have had family members, friends who have got COVID-19 and sometimes even died from COVID-19. Anyone who comes into our hospital, they know what they're up against, and that makes it that much more sad and stressful. And even though cases are down, because critically ill patients stay so sick so long, we're still taking care of plenty of them. These are mostly unvaccinated patients, but if we do have a few breakthrough infections, they are more often patients like General Powell, who are older in age, immunocompromised. But the thing about it is that they're usually infected by unvaccinated contacts. And so even though this discussion sometimes breaks down into individual liberties, this is a collective effort here. And people who have high risk of complications and suppressed immune systems, they need to be vaccinated and need to get boosters, but they really need for everyone around them to be vaccinated as well to really cut down on circulating virus. And as a result of all of these, we started this thinking that we would be doing a sprint. But it turns out COVID-19 has become a marathon. And most of that is because the vaccine effort is picked up steam, but it hasn't gone the way that we wanted to at the pace that we wanted to. And that's led to much more strain on the healthcare system. I want to end by just saying that there is a lot of power in the vaccines to prevent severe disease and critical illness. I do things like this because I don't want people to meet me on a professional basis. I'd much rather you meet me in the street than in the ICU, because that means things are going very bad. But also you decrease the risk of spread to others. And so, maybe spreading to someone who is higher risk, vaccinated or unvaccinated, this is what's at stake here. Long COVID is something that we haven't discussed here, but can affect up to a third or half of people at some point. And these are long-term symptoms, and being vaccinated can protect you against that. And most importantly, it protects the most high risk around us. So even if they are doing the right things, if they're still high risk, they're depending on us for that protection. So I hope that was a good window into what the ICU looks like, and happy to answer any questions.
Great. Thanks so much, Dr. Bell, for such a complete presentation, but also peppered with your warmth, and the stories, I think, really resonate with all of us. So a few questions were sent in from before, and I'll also want to introduce Dr. Baker Smith as well, who's going to be part of the panelists. Hello, Dr. Baker Smith. Dr. Baker Smith is the Director of Pediatric Preventive Cardiology Program at the Nemours Cardiac Center, Nemours Alfred DuPont Hospital for Children. She's an Associate Professor in Pediatric Cardiology at the Sidney Kimmel Medical College at Thomas Jefferson University. Dr. Baker Smith is a nationally recognized preventive cardiologist and transplant cardiologist, and the director of the Nemours Preventive Cardiology Program. She currently serves as chair atherosclerosis, hypertension, and obesity in the Young AHOY subcommittee, the American Heart Association Cardiovascular Disease of the Young. Welcome, Dr. Baker Smith. And maybe we'll start off with you. There are quite a few questions that have to do with kids and COVID. The first one is, can you discuss the AHA statement on myopericarditis and how it relates to young adults and the fears about vaccinating kids?
Yeah, sure. So thank you for having me. Wonderful presentations by all of the speakers today. I just, as a pediatric cardiologist, as a preventive cardiologist, and also as a heart failure transplant cardiologist, I want to reiterate some of what was said today. First and foremost, COVID-19 can and does affect children. I think initially when the pandemic started, there was questions, are kids affected? And yes, let me be clear, yes, they are. And they can be severely so. And that can run the gamut of everything from viral symptoms to the presence of something called myocarditis. So myocarditis is actually, as described by our previous speaker, is inflammation and infection of the heart muscle. And it can happen for a variety of reasons. So I want to also be clear that myocarditis was around before COVID. And if we ever get through COVID, it will be around after COVID. So I don't want parents to walk away thinking that myocarditis was something that just came up just when the COVID-19 pandemic arose. It was here before, and it will be here after. So we don't, exactly know why certain kids or individuals suffer infection of the heart muscle with viruses that we all come in contact with. But that being said, it's no small thing, right? So if I have myocarditis related to Coxsackie virus or parvovirus or COVID-19, what happens is that there's damage to the heart itself. And sometimes people recover from that damage to the heart muscle. And sometimes it requires that they see me for the other hat that I wear, which is heart failure and transplant, and sometimes ventricular assist device placement. So ways in which we support the heart, either through medications for heart failure or pumps, as the previous speaker showed, or even transplant if needed. But again, I want to make this point clear because I talk to parents all the time and they say, I'm nervous for my child to get the COVID-19 vaccine because I'm afraid that my child's going to get this myocarditis. And I want those same parents to know myocarditis was here before, and it's a viral infection of the heart that people develop, and it's not terribly common, but when it happens, it can be severe. The other point that I want to stress, and I'll get to the AHA statement, is that, we treat myocarditis, and yes, certain people recover from it, but myocarditis isn't the only complication of COVID-19. The other complication that we see is something called MIS-C, or multi-system inflammatory disorder in children, and that's diffuse involvement. But mainly, what you see is there is involvement of the heart muscle, and there can be involvement of the blood vessels that supply blood to the heart muscle. So coronary arteries can become enlarged, the function can be compromised, and there can be inflammation around the heart muscle, pericarditis related to this MIS-C. And that's pretty extreme. And we were experiencing a decline in the numbers of those cases, but we're starting to see an uptick. So when we talk about this importance of masking and vaccination and reducing spread of virus in the community, we're talking about helping kids not to develop these bad diseases of the blood vessels of their hearts, these complications that can in fact have long-term consequences in terms of their heart function and their ability to perform. And then we see, cases where kids are affected and, they've removed from sports for periods of time. So there are some also quality of life issues related to the presence of COVID-19 and the viral spread within the community. The AHA statement from 2021 that highlights myocarditis in kids really is a nice summary of what myocarditis is. And the inflammation of the heart muscle that occurs, the damage to the heart muscle that occurs, how we diagnose it, some of the symptoms that children experience. I can talk about that, how we manage it and then treat it, and also long-term outcomes. And so when we think about the presentation, to give too much away, we just admitted, a child last week with myocarditis, and unfortunately he was quite sick. And so, but not COVID related. So these are situations in which they do happen. And the situation is that sometimes kids will present very subtly with signs of heart failure. And that can be everything from just feeling more fatigued, more run down, having less exercise capacity, what they were able to do before, they're not able to do now. And getting that history of a viral prodrome. So maybe they had upper respiratory signs of upper respiratory infection 1 to 4 weeks prior. Sometimes they have abdominal pain. So sometimes heart failure actually manifests in very non-specific ways like that. But there can also be milder cases of myocarditis where maybe they're not as sick, maybe they experience some skip beats or heart racing that's sort of unexplained. Why would their heart be racing at that particular period of time, like in the middle of the night? I've had cases like that. So, it's important for parents to realize that that's a real entity. But again, the take home point is I want parents to also know it's not, they hear about these things about myocarditis and the vaccine. I want the point to be made that vaccination helps to reduce disease burden. It helps to reduce severity of disease, and that's true for kids. And believe it or not, like I said, kids get infected and their risk factors include some of the same risk factors as adults. So obesity is a big risk factor and something that we see in a large percentage, a significant percentage of our kids. But also to understand that we do diagnose it, we do treat it, and many kids will recover, but there are some that will require more advanced therapies and support. And that's what that statement kind of highlights.
Great. And we'll come back to you in a second, Dr. Baker-Smith, for another pediatric question. But I'm going to ask Dr. Robinson now, as succinctly as you can, because I know we can talk about a lot around masking, but there are a lot of questions on masking. And the question is, should we still wear them? And why should we wear them if the numbers are going down? And what happens if we stop wearing them?
Yes, thank you, Dr. Tinhang. I think that's a really important question because I do think there may have been some confusion about masking and where to wear masking sort of throughout this pandemic. And so, yes, even if you are vaccinated, you should be wearing a mask indoors. Because of the increase of the Delta variant and because it is so much more transmissible, you really want to reduce the risk that you have to the number of viral particles that you're getting, given that the Delta variant can infect so many people. And as we are seeing, the vaccinations that we have available are still very efficacious, but their efficacy has gone down a bit with the advent of this new variant. So definitely for those who have not been vaccinated, we should be wearing masks at all times. Those who are vaccinated should still be wearing masks to protect yourself, of course, but also to protect other people who may not have mounted as robust a immune response as you have. So these are still really the foundational approaches that we've used to prevent increases in cases. So these mitigation strategies are still incredibly important. So masking and distancing still need to be taken just as seriously as they were before.
Great, thanks so much, Dr. Robinson. We have another question for Dr. Baker-Smith. If you can come back on video, that'd be great. So these questions are around schools, and is it safe? What's your feeling about taking kids under 12 to school when they're not vaccinated? And what's the risk, not only to the kids, but to the community?
Mm-hmm. Yeah, I think that's a really good question. I mean, I'm a parent myself. I have a little girl who's under, I have one that's over 12 and one who's under. So the over 12 is vaccinated and the under 12 keeps asking, when am I going to be able to get vaccinated? So I think it's really important. I have conversations with the women in my neighborhood as well, and trying to hear different parents' perspectives. First and foremost, I think good communication with the school is key. I do not think we need to take this like rodeo, cowboy approach to this. Wear your mask, okay? Even if you disagree, even if you feel like whatever the argument it is, you do not know who is in your child's class. There are patients that I take care of, my transplant patients, for instance, they don't mask, they don't have the same response to these vaccinations. There are individuals who are at greater risk. It's everyone's responsibility to help your neighbor, to be your neighbor's keeper. We don't live in a society in isolation, right? We're not on an island by ourselves, right? So until that happens, everybody should wear their mask. And it should be, I think that education is important. I'm sure that there are certain kids who do well virtually. There are other kids who learn better in the in-class setting. So I think if we can have in-class education and in-person education, people wear their mask and we can all agree to do so, I think it can save lives. And as I brought home the point before, kids are affected by this, okay? It's not just adults, it's not just the elderly. There are kids who develop coronary artery disease. There are kids who develop, myocarditis. This is not, a benign thing for some individuals. And so they should wear their mask. Everyone should.
Thank you for that great answer. Dr. Bell, I don't know if you can turn on your video. There's a few questions. Hi. So the question is on antibody therapy, and have you used that and convalescent plasma in the critically ill population? And in general, when are you thinking about using antibody therapy?
Sure. So for convalescent plasma, this is basically taking the immune part of the blood for someone who has recovered from COVID, and then infusing that into someone who's newly sick with COVID, with the thought that getting antibodies from someone else who has made them already to someone who may not have them could be a benefit. The studies for that have been very mixed, and we've generally started to move away from giving convalescent plasma, especially in the ICU. The monoclonal antibodies are an interesting story. So the way these work, the name of the game for the vaccine is to inject it in the arm. Your body makes a spike protein, not actual COVID, but just a part of the spike protein. Then you make an immune response to that. So it makes antibodies. But for some people who may not have those antibodies, either because they're not vaccinated, or if they are vaccinated but have suppressed immune systems like General Powell did, then those are people who may benefit from having the monoclonal antibodies. And so in the ICU, this is mostly a therapy that we're trying to use for outpatients. So folks who have COVID, maybe unvaccinated or high risk, and they have a high risk of having severe disease. So older in age, chronic conditions, that sort of thing. But for those who are in the ICU, once they're admitted, we're really looking for those who don't have an immune response. Either because they were not vaccinated or because they were immunocompromised. So we check antibody levels. That's really the only instance where we check antibody levels, because if they don't have a good response, then they could potentially qualify for getting a monoclonal antibody therapy. So I've only used it a couple of times in that sort of scenario, but the challenge is it's logistically difficult to give, because you need an IV, you need an infusion center, and a nurse if you're not in the hospital.
And a follow-up question, Dr. Bell, what about the individuals who think about monoclonal antibodies as a substitute for the vaccine? And as you know, like 75% of the monoclonal antibodies are going to like 5 states. And those are the states where masking and vaccines weren't necessarily on top of people's minds.
Yeah, I don't think this should be an either or. It should be a yes and. And the analogy I would make is that if you looked out my window and saw that there was a storm outside, and I had an umbrella in my office and I had a magazine in my office, you would not take the magazine and put it over your head and walk outside in the rain. I mean, yes, it's going to give you some protection, but it's not going to be good. You'd rather have the umbrella to give that full protection. So in that scenario, the vaccine is like having a nice wide umbrella like you see on golf courses. You get really good protection that way. Having a monoclonal antibody and, relying on things like that, it's more like having a magazine and saying you're going to be good when you're not. So, you really want to get that protection beforehand.
Great, thank you.
I just to add to that. Oh, sorry. I just wanted to say that, just to add to that, I think we also have to remember the idea of resource allocation, and that while a lot of these things are possible, that the administration of them and the systems implementation there is not always as rapid as we want. So for those who are not getting vaccinated thinking, oh, there's a new pill, or oh, there's monoclonal antibodies, we really are working to sort of use those resources in an appropriate way and in the best way for the entire nation and really the entire globe. And so having people who can get vaccinated allows us to have more freedom to use those really precious resources in the best way.
Great, thank you. This question is for everyone, Dr. Robinson, Dr. Bell, Dr. Baker-Smith, and it's really, there are 2 last closing questions. One is regarding the people are still holding out to not getting vaccinated, particularly in communities of color. what is your latest thinking on that, and how your conversation's been, and where do we go from here?
Maybe I'm stepping out on a limb here. I think historically there's been, stories like the Tuskegee experiment and things like that. I've heard people kind of reiterate that this is different. This is not, and I'm not an expert per se on that, but I would say that this is different. The data is here. I mean, you're saving lives. You're not giving something to somebody to make them sick. You're actually saving lives, and we have that data, and we know. 97% of the people who have severe infection are unvaccinated. We know who's being hospitalized. We know who's getting, the more severe disease. The numbers are there. So it seems very odd to me that there's this question. It just, that's my sense of it. I think it's very emotional for people. But, looking at the numbers, I don't see how it's not clear. But, I think people will argue from an emotional standpoint that this is why they believe certain things. And I think you just have to look at the numbers, who's dying. And to say that you're not affected or not going to be affected, I think we all know individuals who thought the same, and they're not here with us today. So I would say get vaccinated, wear your mask.
Thank you.
I would say,
Oh, yes, go ahead.
Makeda, you first.
Please. Thanks. So yeah, I just wanted to say, I think that also finding, for those who are still hesitant, really finding a person in the healthcare system that you really trust is important. And I think, unfortunately, oftentimes people of color don't have that connection with the healthcare system. And so I develop some worry and hesitancy about if this is really the best thing for me, or just kind of like what the party line is. And I think that's why it is so important for things like this, and to have discussions like this, and for there to be outreach into those communities so that there can be a more personal connection. And so I would just hope for anybody who's had those thoughts or has come into contact with people who are questioning it, to really have that one-on-one connection. That's not about like I'm going to dictate what it is that you do, but why are you concerned, and how can I help assuage or answer some of those questions? Because yes, the data is there, and it's been out for a long time, and it's been, we've been told, but a lot of times people are getting their information from places that are not vetting that information well, and are not necessarily using those platforms as a way to disseminate truthful information. So I would say wherever we can, having those conversations is incredibly important. And yes, it's going to be a slower process, a slower kind of one-on-one process, but it's incredibly worth it. And I hope we can all go out and kind of do our part in that space.
Thank you, Makeda.
The thing that I would add is that getting vaccinated for a lot of people has become a cultural and value judgment. And that's been very unfortunate, because I think the vaccines have become a stand-in for political and cultural battles that have nothing to do with health and safety. But that's not everyone. And I don't want to presume that someone who's unvaccinated is in that camp. And this presents a great opportunity to talk about that Nicki Minaj tweet that we're all thinking about. But it was like her cousin, a friend of that cousin, who got the vaccine, and then their genitals got swollen and they were infertile or something like that, and the wedding got called off. It was a moment that a lot of us laughed at, but it ended up being an interesting chance to talk about some concerns that people generally had about fertility and the vaccine. And so how do you explain that in the context of knowing that the vaccines are very safe, they're very effective, they don't cause infertility problems? COVID does cause infertility problems, but you have these stories that people latch on to. And so when I started asking people about this, so what do you think about that tweet? I've probably had about 7 or 8 conversations with people who had not chosen to get vaccinated because they were concerned about fertility. They weren't necessarily concerned about, swelling up or whatever, but that was a general concern. And so that allowed a chance to talk about it. And I said to people like that, there's a morning where I tried a completely new flavor of coffee that I'd never tried before. And then I walked outside to my car and I twisted my ankle. Now, would I go back and say, okay, I don't usually twist my ankle, I've never drank this coffee before, it must be because of the coffee? The fact of the matter is when you're giving millions and millions of vaccines to people, things are going to happen to folks just because things happen to folks. And it might be close to when you got the vaccine, but you can't make that connection. And so this person probably got a sexually transmitted infection. It just so happens that they got vaccinated around that time, but there's no link there because the science does not support that. And so I think, trying it's hard. It's so hard now because we know so much and we support the vaccine so much that when we see someone who's unvaccinated, our reaction is to approach them in a negative way, but there's still a chance to dig in, find those underlying reasons. And you can still find wins when you talk to people about this and engage.
Thank you. And I was just reminded of a survey that I saw that only 17% of unvaccinated folks actually had a conversation with someone. So I think we have this idea that they're all like closed, but nobody's talking to them, as each of you said. I know we are at the half hour now, but I wanted to just close on one question to each of you, which is, what keeps you up at night? Starting with Makeda, about the pandemic.
Oh, yeah. Wow. What keeps me up at night is the fact that is vaccine dissemination worldwide. Because I think that we have an idea that we can booster shot our way out of this pandemic. But the truth is, the longer that this virus is maturing and mutating in the human host, the more likely that a new variant could pop up. And if it pops up in a place with a very small percentage of vaccinated people, it can take off again like wildfire. So I guess what keeps me up at night is the next Delta variant in a country that has, less than 10% vaccination rates that can then spread again. And the fact that we have not actually built as much infrastructure as we need for the next one.
Thanks so much, Dr. Robinson. Dr. Bell, do you have what keeps you up at night?
What keeps me up at night are just some of the stories of people that we've lost so far, and especially now in the midst of, these are preventable deaths. And so, I think about the children who don't have their parents, the weddings that won't be, had at this point. And, one of my patients, built engines from scratch in his kitchen, and his wife hated it, but she also loved it at the same time. And those engines aren't going to get built. And, just the loss that's there, that's ongoing when it's preventable now, that's what really keeps me up at night, that we're still seeing this, unfortunately.
Thank you, Dr. Bell. Dr. Baker-Smith?
I think what concerns me the most is our ability, and I'm not speaking for all persons in society, but our ability to sort of, work out what's so obvious, like not the denial, I guess is what bothers me. I mean, it's like somebody handed you the answers to the test and you still failed, right? Like here are the answers, here's your test, and you still failed. I feel like that's sort of a similar situation. We have the answers, it's right here, and it's not being adopted. And we were talking through these situations, talking ourselves out of it. That concerns me. And then the other thing that concerns me is, when's the next variant? And maybe we won't be able to be as successful in terms of our ability to use science to combat that variant. And that concerns me.
Well, thanks to all of you, Dr. Robinson, Dr. Bell, Dr. Baker-Smith, for such a wonderful, clear, succinct, and presentations full of humanity as well. And to the audience, I'm sorry we couldn't get to all the questions. There were many great questions, but hopefully you got a glimpse into where we're going. There's still a little bit of uncertainty. And as Dr. Baker-Smith said, we have many answers. So hopefully we can all score A's on our test. And I just wanted to end with a quote from Colin Powell, who said, "A dream doesn't become reality through magic. It takes sweat, determination, and hard work." So nothing is easy. Getting unvaccinated people vaccinated now is not going to be easy. It requires work, it requires conversations. The future is not easy, but I know we'll get there. And thanks so much for joining us today.